And so these laws are not, they're consistently putting that decision into the hands of the physician or clinician who is at the bedside in front of the patient. And so please be reassured by that. Okay. If this is not something that is causing major problems, in emergency departments in one of the most pro-life states in the country, then you should feel empowered to do what you feel is immediately correct for the patient. Okay.
Hi there, this is Miriam Diallo, AAPLOG's Communications Manager, and if you were here for last week's episode, you'll know that this is going to be part 2 of a 2-part conversation between Dr. Christina Francis and Dr. Sean Hutzler, an emergency physician, about EMTALA, the Emergency Medical Treatment and Labor Act. So we'll jump into that in just 1 second, but first I wanted to make a bit of a personal announcement, which is that this is going to be the last podcast episode I'll be joining you guys for. After 3.5 amazing years as AAPLOG's Communications Manager, I will be taking a step back from that role. And that was an extremely bittersweet decision to make because these past few years have been absolutely amazing. It's been such an honor to work on this podcast and a bunch of other things with Dr. Francis and Dr. Bain, as well as to see all the amazing guests we were honored to have on. I look forward to seeing where this podcast is headed next because while this is my last day on the podcast, it is not the podcast's last day, and it will continue under Dr. Francis and Dr. Bain's leadership, as well as that of the next communications manager. So I look forward to seeing where this podcast is headed, but in the meantime, let's just jump in and enjoy this second half of the conversation between Dr. Francis and Dr. Hutzler. I hope you enjoy.
So, you brought up some of the Texas cases and the idea of medical malpractice, which I think, a lot of the cases that have sort of been splashed around in the media as women being harmed because of a state's abortion law, many times are, as you said, a case of medical malpractice. There was the case of Amanda Zarowski v. Texas, a woman who had previable rupture membranes and ended up becoming septic. And the Texas Supreme Court ruled that that was a medical malpractice case, actually, that her doctors could have intervened under Texas law, but chose not to, and they should have intervened. And that would have prevented some of the morbidity that she experienced. And so I think that's a really important point to make. The other thing that stuck out to me as you were talking is that I don't know that I've ever actually thought about this before in these terms, but EMTALA actually places stricter standards on which patients have to be treated than even state abortion laws do. So there's not a single abortion law in the country that requires that a woman be actively dying or that death be imminent for her in order to be treated. They actually state that according to the treating physician's reasonable medical judgment, that she could be facing either a life-threatening condition or, in many states, they also say, or permanent physical impairment due to, dysfunction of a major bodily system. So that's actually gives doctors, the abortion laws actually give doctors way more latitude to intervene versus, EMTALA, as you said, is dealing with a very specific set of circumstances, which is this patient is facing an immediately life-threatening medical emergency. And so we have to intervene and treat. And so, so the state abortion laws are actually much more permissive. They don't require that a woman be imminently in danger before a physician can intervene. So I think that that's also an important point to make. And also for physicians to understand that they don't need to wait to intervene if they see a woman if they're practicing in a pro-life state and they see a woman who, has an ectopic pregnancy or is facing, she's previable rupture of membranes and she's infected. They don't need to wait to intervene and find out from their hospital attorneys if it's okay for them to do that. Every state law allows for us to intervene in those situations. And we definitely don't want to delay patient care out of fear.
Sure, and some of the specific types of clinical scenarios that are brought up in these legal cases over and over again are things, like we mentioned earlier, like ectopic pregnancy. So there's not a physician that I'm aware of who's actively practicing and taking care of women who are potentially having ectopic pregnancies that believes that ectopic management is an abortion. Okay, and so there's in fact, I've the closest thing that I, as an emergency physician in 10 years of practice, have come to participating in and around something that could vaguely be considered an abortion was a cervical ectopic that had a heartbeat.
Mm-hmm.
And the sad reality in those situations is yes, like this is a child, this is an unborn child, but this pregnancy is, there's no way, and not only are they not going to go to term, they're actively endangering both themselves and the mother. And so in that case in particular, the condition resolved itself without the need for a surgical intervention. But I mean, I'm Catholic. I transferred that woman to a specialty center that could do the procedure that she needed, and I felt fine about it. I slept fine that night.
Right.
And this is, so management of these conditions is not the same as an elective abortion. And I think that's very important for the public to understand. Mm-hmm. And you mentioned it, malpractice, and I know you wanted to talk about patients and advocating for themselves a little bit later. There's a very similar case to Zorowski, but unfortunately the young woman passed away in Beaumont, Texas, almost 2 years ago now, where a woman essentially was having a miscarriage and it developed endometritis and sepsis and died. But when I look at even what is, and I have to, take what's reported in the popular media with a grain of salt, but when I look at the series of events that led up to this young woman's death, it's extremely clear that at multiple stages in her care, the physicians involved were committing malpractice. Mm-hmm. When she a woman who's pregnant in her first trimester showed up to an ER with a fever, the first ER visit that she just had a strep swab and then was discharged. And, even though she was reporting abdominal pain and bleeding and discharge, and and she was even, seen by an OB at a second visit, and did not have her condition managed appropriately. And none of that involved abortion care. Like I know, there wasn't a, saying, this is what, needs to happen at this other time. They didn't act to take the appropriate intervention,
right?
In the same way that somebody who, has something that's not an immediate emergency, perhaps they have an issue and a reason for wanting an abortion that they feel is justified. But if somebody is hemodynamically stable, if there's no immediate threat to life and limb, then these kind of judgments don't apply in those clinical scenarios.
Yeah, absolutely. Absolutely. Well, and you make an important point that, not a single state law in this country outlaws a doctor doing a DNC. It's just They might outlaw doing a DNC for the intent of an elective abortion. So if the only intent is to end the life of that baby via DNC, then sure, that DNC is illegal in states where abortion is illegal. But there's not a single state law that would prevent me from doing a DNC on a woman like that patient, who is infected, and you need to empty her uterus in order to save her life. So that is a very, very important point to make. And we still continue to hear stories. Representative Kat Kammick from Florida wrote out her story in the Wall Street Journal about going to a hospital with an ectopic pregnancy, and her doctor hesitated to intervene. It was after Florida's heartbeat law had gone into effect. And, she knew her state law well. And so she knew that law didn't apply in the case of ectopic pregnancy, and was able to advocate for herself. And so thankfully she received the care she needed. But you and I both know what a traumatizing situation that is for a patient when they've been told that, oftentimes these are very wanted pregnancies. And then, they're being told that it's an ectopic pregnancy that has no chance of survival. And, That's already a traumatic experience for a woman and her family to go through, but then to have to advocate for themselves on
Right.
top of that to say, you need to give me the treatment that I need, just to me feels like it adds insult to injury. But I'd be interested to hear from your perspective as an ER physician, and you're dealing with patients in these emotional and emergency situations all the time. What would be your advice if a patient is either afraid to go to an emergency room if they live in a pro-life state because of an emergency situation, or maybe they're in an emergency room and they feel like maybe somebody's hesitating to give them the care that they need? What would be your advice to a patient for some ways to handle that situation?
Well, and I say this as, from the perspective of somebody, in one of my, one of the facilities that I work at is one of the only women's hospitals in our area. And so I do see a large volume of pregnancy complications before 20 weeks. I want to first of all, reassure patients that though you do hear about these cases that are blown up in the media, et cetera, that the need for immediate intervention, and particularly in cases of complex miscarriage management, endometritis, and things of that nature, are not particularly common. Okay.
Mhm.
And the vast majority of first and early second trimester miscarriages will resolve on their own, not need an urgent, intervention, surgery, may, benefit from some medications, etc. Even ectopic pregnancies early on, before the detection of a heartbeat on ultrasound, will resolve through your body's own physiologic mechanisms with time. Some, a good percentage of the time. And some of these are cases that we don't even know about. I mean, I'm sure, you've seen in your practice, a woman who's, extremely early pregnant, 3 or 4 weeks, and, but may not even know it, and just, has a period that's significantly heavier than is previous, but they may actually be having a miscarriage. And so the urgency with which some of these conditions are addressed is, people hear ectopic pregnancy or they hear miscarriage, and part of the overall milieu of American healthcare is, well, we got to get it fixed right now. Okay, we got to get this done right now. Whereas, something like a referral for an elective DNC, if after sometimes a week or two, for retained products of conception or retained pieces of placenta, that's clinically appropriate. And so keep that in mind. Okay. But of course, not to dismiss, what women are experiencing. If you feel that you need a more urgent intervention, press your physician, who is the person who's caring for you, as to why it is that an urgent or emergent intervention is not necessary, because there's probably a reason. Okay. And I end up having this conversation not infrequently. And I work very closely with a large group of private OBGYNs, next door to my hospital, as well as the OBGYN hospitalists that are stationed in our labor department, or they call it an OBED, OBER. And so that there's probably a reason why.
Mhm.
And I couldn't, you mentioned the congresswoman who published her case in the Wall Street Journal. She ended up having a surgery, I believe. Is that right?
I think so. I can't remember if she had surgery or if she was treated with
Or got
methotrexate.
methotrexate, yeah.
Yeah, but she did end up getting treatment. It's just she
Sure.
had to push and say it wasn't our law that is, that it
Right.
would keep you from doing that. Yeah.
Right. Yeah. Actually, I remember reading that, and like the irony of some of the folks on the other side saying, "Haha, even this Republican congresswoman, is butting heads with abortion laws." But it's not abortion. It's ectopic pregnancy management. And again, I think that I won't say that there's not some philosophers out there who, debate, how we should and shouldn't treat ectopic pregnancy in an ethical or moral way. But I don't think there's a single physician in the United States that, when you're talking about managing ectopic pregnancies, is considering that to be the same moral choice as an elective abortion on demand. And that is, we manage early ectopic pregnancies all the time. And many of them are managed on an expectant basis. In fact, there were some studies that were done that, before a certain period in the first trimester, methotrexate versus expectant management, just waiting to see whether it resolved itself or not, had about equal rates of success and equal rates of needing to go to surgical management. And so that's not something that I expect a patient to know in detail. That's the job of your physician, okay, to know those and to make those clinical judgments. But press them to say why. Okay, why are we not going right now? And there will often be a reason. Okay, and if they don't, okay, the hallmark of good emergency care for anybody being discharged or not having an urgent intervention is return precautions and discharge instructions. Mm-hmm. And so if it's not clear to you what should change, what are the things that should change that would make me come back, that would need this urgent or emergent intervention, then make sure that those things are clear before you leave the hospital. I tend to be fairly detailed in my discharge instructions and very specific in the things that I list as reasons why somebody should return to the emergency department. And those include things like signs of rupture for ectopic pregnancy, signs of ascending infection and endometritis in the case of preterm rupture membranes. And in my years of practice, and I have not been in practice, the longest, okay, but in 10 years of emergency medical practice, I have, never encountered a situation where an elective abortion was a right now emergency medical decision. Okay. 2, I have not, in my practice, felt uncomfortable. Okay, even before Dobbs, when Texas had some of the most stringent pro-life laws in the nation, the heartbeat bill from 2012, that I have not felt uncomfortable providing those services in Texas, in that environment, even though we have one of the most aggressive state attorney generals in the nation, which that's a whole nother can of worms to talk about. But there's not been a prosecution for somebody providing miscarriage management or ectopic pregnancy management in Texas. The boogeyman to the pro-choice, person of America.
That's right.
That they're not coming after us for providing good medical care. Okay.
Right.
These laws are meant to be applied to those that are procuring elective abortions.
Yeah, absolutely. Well, and I think you bring up a good point in that, there may be many reasons why your doctor, and if you're going to the emergency room, may not recommend immediate intervention. But it's a good thing to ask them why, because if they were to say that it's because of their state law, then you need to push back and say, no, I know that our state law allows for doctors to intervene for medical emergencies. But it also very likely could be another reason, some of those that you laid out of, here's what we can expectantly manage right now. We don't need to do an intervention right this moment. I've had patients come back where it's unclear what is going on with their pregnancy, that it could just be a very early intrauterine pregnancy that we don't want to do anything to interrupt. It could be what we call a pregnancy of unknown location, where maybe it's an ectopic, but maybe it's in the uterus. And so we want to give the opportunity for that baby to continue to grow and sort of declare him or herself of where they're at. So it might be that, or it may just be that, the doctor thinks that it's good for the patient to have some time to make those decisions. But I think the most important thing to stress here, especially with ectopic pregnancies, because certainly those can be life-threatening, that you should get checked out. You should have an evaluation by a physician and talk about your options for management of that ectopic pregnancy. And that's allowed in all 50 states. And so, you definitely should be seen. And, certainly as an organization, we are happy for patients to reach out to us if they don't feel like they're getting that kind of care for some reason. But again, encouraging communication between you and your physician.
Absolutely. And you touched a little bit about this, and, so from the physician perspective, okay, or nurse practitioner or PA or whoever it is that you're seeing in the ER, I hope that what I've said is somewhat reassuring, that even in one of the most, stringent anti-abortion states in the union, that I've not had once, okay, a major any kind of legal trouble from providing ectopic and miscarriage management. And for as much flack as pro-life organizations get for legislating morality, legislating the patient-doctor relationship, the court cases have consistently held that they want to keep that decision between the patient and their physician. Okay, they want to keep that they don't want to make these blanket laws that could potentially inappropriately apply, right? They don't want to say, whenever there's a heartbeat, you can't do an intervention, because that would eliminate, later term, ectopic pregnancy management. They don't want to, say that any, evacuation of the uterus is, constitutes a direct or elective abortion, because then again, there are clinical scenarios where that is appropriate. Okay, not only appropriate, but moral and ethical and necessary for that to happen. And so these laws are not, they're consistently putting that decision into the hands of the physician or clinician who is at the bedside in front of the patient. And so please be reassured by that. Okay, if this is not something that is causing major problems, in emergency departments in one of the most pro-life states in the country, then you should feel empowered to do what you feel is immediately correct for the patient. Okay,
absolutely.
Unless what you feel is correct for the patient is to have an elective abortion on a hemodynamically stable woman.
Right.
Like that's not that's not the clinical scenario that we're addressing.
Yeah.
And I would, again, this is just general good advice for all medical professionals, is documentation. Okay.
Yes.
Document the why. Document why it is that you feel that this is a medical emergency, because I can guarantee you that the judge, okay, if there's any kind of legal action, the judge, the jury, these people are not medical professionals. Okay, they don't have your training, they don't have your experience, and so if you feel that emergent intervention is necessary to prevent some life-threatening condition, then document why. Okay.
Absolutely.
And in general, okay, for example, you mentioned the Zurofsky case, they will say, well, this is clear that this is something that should have been done. I mean, these are not completely unreasonable people. We just have a vested interest in protecting some of the most vulnerable, members of our human family. But this is not, we're not trying to control people. We're trying to protect those, those unborn children out there. But that doesn't mean that we're blind to reality, right? Absolutely. And so the management of these conditions is appropriate, is ethical, okay? And you should, I hope, all right, be reassured by this and feel empowered to do what is right for your patient, and that includes complex miscarriage management, ectopic pregnancy management, endometritis, PPROM, all of those things. Do what's clinically indicated, okay, and is necessary to prevent an emergency.
Absolutely. And if there's any, physicians, other medical professionals listening to this that still have concerns or would like to find out more information, that's actually why AAPLOG produced an incredible continuing medical education video on this very topic, where we have a maternal fetal medicine specialist and an attorney talking about exactly what Dr. Hutzler and I have been talking about today, about how we can still intervene to treat emergency situations in pregnancy in every state in the country, and the importance of documentation too, as you said, documenting your thought process of why ending her pregnancy or making that intervention was really the best and only option for her. So if anyone is interested in those videos, you can find them at meded.aaplog.org. Dr. Hutzler, thank you so much for joining us today. This was a great conversation, and hopefully people not only understand a little bit more about EMTALA and how it is meant to protect them, but also how it allows for us to protect the most vulnerable amongst us, like you said.
Thanks so much for having me.
Thank you. And thank you to our listeners and our watchers for joining us today. If you liked this episode, please be sure to give us a like and a subscribe on YouTube. Or if you're listening on a podcast app, give us a 5-star review so it'll bump us to the top of people's lists. We continue to provide clarity in the midst of so much confusion and medical misinformation that is out there. If you are appreciative of that, or you know others who are, please encourage them to join us and partner with us. You can donate to continue to make this work possible. You can do that at applog.org/donate. Thank you so much, and we'll see you on our next episode.